And then he's also, of course, part of Gavi, which is the Global Alliance for Vaccines and Immunization. So without further ado, let me welcome Dr. Cochi, who will be talking about childhood immunizations at the Crossroads, opportunities and challenges.
Well, thank you very much, Ben, and certainly the subject of this conference is a very important one, very close to my heart, and I'm very happy to have been invited to participate with you, and I appreciate the fact that you've come out on a Saturday morning to join us all. I'm going to focus on the domestic, the U.S. immunization program today, and what I hope to achieve is to set the stage for the rest of the speakers in this session this morning by pointing out that despite the many successes in the U.S. immunization program, we face a number of ethical dilemmas to sustain the work that the immunization program has been able to accomplish. The overriding theme that I want to convey to you is that vaccines are one of the most important tools that we have to protect the health of our nation's most vulnerable citizens, our children. And the major immunization program values for all of us who work in the immunization system are first and foremost equity, being able to deliver these life-saving vaccines as benefits to all children, both in the U.S. and globally. The impact that these vaccines have is a tremendous part of the success of the immunization program, and it represents an important value, and along with the effectiveness and the efficiency of being able to apply these public health interventions. In order to be successful, it's essential to develop partnerships between the public and the private sector, and I think the U.S. immunization program represents a very excellent example, since most immunizations are given in the private sector, of very close work and relationships between the public sector and the private sector to accomplish the immunization enterprise. Now, a little bit more about what we're about. I want you to focus on the bubble at the lower left-hand part of this slide. The immunization system's goal is to achieve and maintain high immunization coverage rates for all age groups. And in so doing, if you move to the top of the slide, we achieve the disease prevention, the reduction in morbidity and mortality from vaccine-preventable diseases. We've been very successful at this. And this, we hope, will instill confidence in the immunization system and the vaccines that we use on the part of the public. It's very important that we not only achieve that confidence historically, but that we maintain and sustain that confidence, that public confidence in vaccines, which is particularly difficult when the diseases disappear and are no longer a part of the concerns of people's activities of daily living. But we have had and we will continue to have big goals in the immunization program, whether it's eradication of smallpox or polio, or the elimination of various vaccine-preventable diseases in the United States and globally. The Healthy People 2010 goals call for having, by 2010, 0 cases of congenital rubella syndrome, diphtheria, Hib disease, measles, mumps, polio, rubella, tetanus. And also has as a goal the elimination of health disparities, racial and ethnic disparities in immunization coverage and in disease occurrence. On the global scene, we have regional targets in 4 of the 6 WHO regions for the elimination of measles, in 2 of the regions for the elimination of rubella and congenital rubella syndrome, and then in 2 of those regions, the reduction in chronic hepatitis B infection. So these disease reduction targets are characteristic not only of the U.S. Immunization system, but globally. We have a global mortality reduction goal for measles, which until very recently was the leading childhood vaccine preventable disease killer of children, causing about 1 million deaths per year. And now that, with a 5-year initiative from 2000 to 2005, that disease burden has been reduced by more than 50%. And that's in keeping with the Millennium Development Goals that all of the member countries of the World Health Organization signed on to, which involved the reduction in under 5 child mortality by 2/3 by 2015 compared with 1990. And the reduction in measles and some of the other vaccine preventable diseases that you heard about yesterday, like pneumococcal disease and rotavirus, hold a lot of promise in terms of being able to achieve that Millennium Development target for under 5 child mortality. So in short, the immunization program, the childhood immunization program in the U.S. has had many successes. Vaccine preventable diseases are at an all-time low. They're record high coverage rates. Measles is no longer endemic in the United States and in the Western Hemisphere since the year 2002. We've been able to sustain that. Rubella has been declared officially eliminated from the United States, and there's a regional effort to interrupt rubella transmission in the Americas by 2010, which is ahead of schedule. Now, another feature of our success is that we have been able to prevent more disease by the introduction of new vaccines, and there's been a dramatic change in the face of the program over the past 20 years. Back in 1985, there were only 7 vaccine preventable diseases that were part of the routine childhood immunization schedule, as you see in the left-hand column. By 1995, that number had increased to 10. But as of this year, and this slide is already out of date because 2 weeks ago, the human papillomavirus vaccine was recommended by the ACIP for routine vaccination of young adolescents, girls, beginning at 11 to 12 years of age. So there's actually 16 vaccine preventable diseases that now have become part of the routine childhood immunization schedule, which is a remarkable change over a 20-year period. Just looking at some of the newer vaccines that have been introduced within the past 10 years, here's varicella vaccine introduced in 1996, and this is a graph showing the rate of ambulatory visits related to chickenpox by age group. The red line shows the children under 10 years of age, the main target group for vaccination. And then the lines at the bottom of the graph show older children in the green and adults 20 to 49 years of age in the yellow. So you can see that not only have there been direct benefits of the introduction of the varicella vaccine, but there has been a herd effect in terms of reducing, even in adults 20 to 49 years of age, the frequency of ambulatory visits for chickenpox. Another example, this is the pneumococcal conjugate vaccine, or PCV7, first introduced into the routine schedule in the year 2000. And you see denoted by year of age the reductions in all of the age groups targeted of children under 5 years of age who were covered by the vaccine. In a very short period of time, a dramatic decrease in the incidence of invasive pneumococcal disease. And over to the far right, you see that those the 2004 incidence versus the baseline incidence pre-introduction, that reduction is anywhere between 49% in the oldest birth cohort to 83% in one of the younger birth cohorts. And again, in the case of this vaccine, there have been dramatic herd effects or indirect effects of the control of invasive pneumococcal disease in children, young children targeted by vaccination, reducing the incidence of disease in adults who are not targeted for vaccination. So the indirect or herd immunity, as you see in this slide, with reductions anywhere from 26% to 53%, depending on the age group of interest. Hepatitis A, with the targeting of high-risk Western states with routine hepatitis A vaccination of young children, the incidence, which shown in the left map graph, 1987 to 1997, which was quite high, in excess of 20 per 100,000 population in the red colored counties, and 10 to 19 per 100,000 population in the orange colored counties. You see, once that recommendation was implemented, by 2004, there has been a marked reduction in hepatitis A incidence, and so that there is no longer are the Western states at high risk. And to sustain this success, the ACIP last fall decided to introduce in all of the 50 states of the United States universal hepatitis A vaccination of young children. When we look at hepatitis B, first introduced into the infant immunization schedule routinely in 1991, there has been a dramatic reduction in all racial and ethnic groups in the incidence of hepatitis B disease, and a near elimination of racial and ethnic disparities. So vaccines can be the great equalizer from a public health standpoint. And in contrast to the situation in the 60s through the late 80s, where we were having difficulties in age-appropriate vaccination of preschool-aged children, and coverage levels for the routinely recommended vaccines hovered in the 60 to 80% range. We got a wake-up call when we had a resurgence of measles, a very large measles epidemic in 1989 to 1991 with 55,000 cases and more than 120 deaths. And the immunization system and program has been substantially strengthened since then. So you can see on the right side of this figure, we are much more effective in achieving on-time high immunization coverage of 90% or greater with the routinely recommended childhood vaccines. And when a new vaccine is introduced into the schedule, as you see for the case of varicella and PCV7, the system is strong enough to result in a pretty rapid increase in uptake of the vaccine over a fairly short period of time. One of the Healthy People 2010 goals was to achieve at least 80% coverage nationally with the series complete, the 43133. I won't go into all the details of what those vaccines are, but basically coverage by 2 years of age with all the routinely recommended vaccines. And we have already reached that target, exceeded that target. We're at 81% in the data from the 2004 National Immunization Survey. So that is another success. So vaccines are protecting more children against more diseases than ever before in history. And there's a big payoff for each birth cohort vaccinated in accordance with the schedule. 33,000 lives are saved, 10 million cases of disease are prevented, and most of these vaccines are not only cost-effective, they're cost-saving, meaning that for every $1 spent on an individual vaccine, the return on that investment from a societal standpoint is much greater than $1. And you can see here, for DTaP, that saves $27 for every dollar invested. For MMR, a savings of $26, and so on and so forth as you move down that list. So it's one of the most cost-effective and impact-effective interventions that we have in the health system today. Okay, that's the good news. Now let's move to the challenges, which I think are going to be the subject of much discussion throughout the rest of the morning. We do have the great benefits of new vaccines, but these represent challenges to the immunization system to incorporate these vaccines into the schedule and get the recommendations implemented. We have vaccine financing challenges, and I'm going to get into each of these very briefly, individually. The challenge of establishing and maintaining a steady vaccine supply, which has been a source of much difficulty and angst for all of us who have worked in the immunization program over the past several years. Reducing the remaining racial and ethnic disparities in coverage so that we can achieve that value of equity, and addressing unfounded fears about vaccine safety. So let's start with the introduction of new vaccines. There's a dizzying array of new vaccines and new vaccine indications that have become a part of the childhood immunization schedule just over the last 2 years. And the number of those changes in the immunization schedule are shown here. The introduction of meningococcal conjugate vaccine for adolescents in February of 2005. TDAP for adolescents as a booster dose. The availability of the combination measles, mumps, rubella, varicella vaccine beginning in the fall of last year. Universal hepatitis A for young children. The recommendation for routine rotavirus vaccination of infants beginning in February of this year. Expanding the influenza target age group for routine vaccination from 6 to 23 months of age to 6 to 59 months of age. Human papillomavirus vaccination of young adolescent girls, and the second dose of varicella now routinely recommended as of the June 2006 ACIP meeting. There are weak points in the financing of the vaccines in the U.S., particularly the financing of newly recommended vaccines. We have a problem with getting congressional funding from the U.S. Congress, state funding to help finance the introduction of these newly recommended vaccines, and getting that funding in an adequate and in a timely way. This is discretionary funding, and that's become an increasing challenge. Also on the managed care and private insurance payment side, there can be a lag period of months to a year or more before the payment reimbursement schemes get sorted out. And we have the ongoing problem of providers getting an adequate administration fee to cover their overhead costs of delivering vaccines in the office. Now, very briefly, I want to tell you a little bit about the different sources of financing for childhood vaccines. In the public sector, we have the Vaccines for Children program, which is a federal entitlement program for poor children. We have what we call the 317 Immunization Grant Program, which is a federal discretionary immunization grant program for state immunization programs. State funds, the state childhood immunization, state children's immunization program, and other public sector financing sources. On the private side, we have health insurance, we have managed care, and then out-of-pocket payments by parents. So it's a dizzying array, patchwork of financing. Now, to focus on the two main federal sources of funding, this table really compares and contrasts these two. The Vaccines for Children program has really been a godsend in terms of, for a variety of reasons. It's a mandatory entitlement program compared with the discretionary annual appropriation through 317, which incidentally has been pretty much flat for the last 5 years. Congress has not increased this discretionary funding in spite of the fact that there have been all these new vaccines and new vaccine indications over the past several years. The eligibility for VFC, which covers a little over 40% of the total of all children under 5 years of age, under 19 years of age, and that eligibility is based on being Medicaid eligible, uninsured, a Native American or Alaska Native, and in some instances underinsured if those children go to federally qualified health centers to receive their immunizations. The eligibility for the 317 discretionary funding is not restricted. So these are more flexible funds that state and county health departments have to deliver immunizations according to their particular needs. So there's significant fluctuations in the stability of the funding on the discretionary 317 side, but the great thing about the VFC is that the funding meets the program needs. When there's a new ACIP recommendation, then the entitlement program kicks in and adequate funds are made available to cover the VFC eligible children. The 317 funding is mostly for the public sector, whereas with VFC, this is a public-private partnership, and VFC really provides vaccine and funding for the administration of that vaccine to approximately 120,000 health providers around the country, most of them in the private sector. Now, another feature that has caused a growing crisis in financing, and it represents one of the ethical dilemmas that we're facing, is that with the introduction of all these new vaccines and vaccine indications over the past 20 years, the cost per fully immunized child has increased enormously. In 1985, it only cost $45, and this is just for the vaccines. I should point out this is just the vaccine costs. $45 per fully immunized child with the routine immunization schedule that pertained in 1985. That has mushroomed to $631 per fully immunized child as the cost of the vaccines in the public sector. Now, this already is an underestimate because this bar graph doesn't include rotavirus vaccine and the human papillomavirus vaccine, which, if added to a revision of this slide, will push the cost per fully immunized child above $1,000, anticipating that it will cost about $110, $120 per dose for human papillomavirus vaccine, and a 3-dose schedule will really push that up a lot. Another feature of this is that the newer vaccines are substantially more costly than the traditional vaccines, and you see as a good example that very large orange part of the bar, which represents the PCV7, or the pneumococcal conjugate vaccine, which nearly doubled the cost per fully immunized child when it was introduced into the routine schedule in year 2000. So with this emerging financing crisis, we have lots of challenges before us. Going back to the 317 discretionary program, the flexible funds the state immunization programs have, there's been quite an erosion in the purchasing power of 317 funds. Back in 1999, those funds could fully immunize about 750,000 children per year in the United States. With the lack of any increase in funding over the past 5 years, combined with the added demands of introducing the new vaccines recommended since 1999, there has been about an erosion in the purchasing power, as you see, of about 50% down to 370,000, an estimated 370,000 fully immunized children per year. And that's going to plummet substantially further when we add the rotavirus and HPV to this analysis. So this is creating more difficulties and challenges for state immunization programs. And we have the problem that has emerged over the past several years of the two-tiered systems and ethical tensions created by that. And the potential for missed opportunities to vaccinate children when they present at a particular health provider. Of course, not all of these missed opportunities are created equal. If you may have a fully insured child who presents for immunization at a public health clinic, so they have an alternative, although increasingly that fully insured child may not have adequate first dollar coverage for vaccines. There may be a very high premium, there may be very high copays. So that's a situation that's not so clear anymore. We have underinsured children who present to a public health clinic and may have to be turned away, particularly when it comes to the delivery of these new and more costly vaccines where there's inadequate flexible 317 funding for state immunization programs to be able to serve all underinsured children. They can serve the uninsured children who qualify for VFC. So you have a paradox where the poorest children can get served, and children who may be on the margin of poverty but don't qualify for VFC would have to be turned away. And the same situation pertains to a private pediatrician's office who serves VFC patients and has an underinsured child presenting for immunization. So turning away children based on ability to pay is very difficult for physicians and for the state immunization programs, and it has liability concerns. It raises questions about the implementation of the Hippocratic Oath, and it creates issues with respect to what are the limits of, what are the boundaries of the VFC law in terms of covering children who are on the edges like this. Very vexing problems. Now, another challenge, vaccine shortages, which have seemed to have plagued the immunization system over the past several years, as shown by just a few of these newspaper headline clippings. We've had shortages that over the past, since the year 2000, encompass 11 of the now 16 vaccine-preventable diseases that are part of the routine childhood immunization schedule. And in some instances, there have been vaccine shortages on repeated occasions, as for example, the influenza vaccine in 2000, again in 2003, 2004, and 2005, and the PCV7 pneumococcal conjugate vaccine. We had 2 different periods where we had to deal with shortage situations. These are vexing problems to address because for most of these vaccines, there's only a single licensed manufacturer supplier in the United States. So there's a monopoly, and if there's any problem with the particular passing of particular lots of vaccine or some problems with the manufacturing process that might interrupt the supply, then that creates a crisis very quickly. So there are a number of ways that these shortages can be prevented. In the longer term, if we had more manufacturers in the marketplace, then that would help to ameliorate the potential for these kinds of shortages. But while we're working toward that end, the expansion of vaccine stockpiles or strategic reserves of these vaccines, 6-month supplies that could be tapped into, called upon when a shortage threatens, is a part of the landscape now where we're working on building those stockpiles for all of these vaccines. Increased support for regulatory agencies. The FDA does a fantastic job with too little resources, and and desperately needs to have more help to be able to carry out its mandate. I think that would be very helpful in terms of lessening the potential for shortages. Maintenance and strengthening of liability protections for both providers of vaccination and for the manufacturers. A national campaign to emphasize the benefits and value of vaccines may be helpful because the vaccines are taken for granted by our society now, and they're undervalued. It's just assumed that they're going to be a part of the public health landscape and don't need to be nurtured. But that situation clearly needs to change, especially with the newer, more costly vaccines becoming a part of the schedule. Financial incentives for manufacturers to bring more manufacturers into the marketplace, as well as streamlining the regulatory process. And one example of this is the harmonization of the requirements for data for gaining a license. If more interaction between the U.S. and other industrialized countries where certain multinational vaccine manufacturers may have conducted clinical trials, allowing those data, if appropriate, to be used as part of the license application in the U.S. Another challenge that I had on my list, reducing remaining racial and ethnic disparities in coverage. Although we've been very successful for the individual vaccine antigens in virtually eliminating the disparity in coverage at 2 years of age, when you look at the series complete schedule at 2 years of age, there are still substantial differences by race and ethnicity in coverage levels. The red bar, these are data from 2000 to 2004. The red bar is the overall U.S. national coverage figure, and then it's broken down by white children in the yellow, black children in the blue, and green in the and Hispanic children in the green bars. And you see for each year that there is a gap, a disparity on the order of 10% in the series complete coverage between white U.S. children and black U.S. children for all of the years of study. That gap is not closing. We're still trying to understand the reasons for this gap, but I'm sure they relate to access, they relate to these financing issues, they may relate to receptivity to vaccination by certain communities in the U.S., and this is something we need to understand better, but more importantly, we need to close this gap. And finally, unfounded fears about the safety of vaccines have been an ongoing challenge. Many of you heard Neil Halsey's talk yesterday about thimerosal. I wanted to use that as an example that is on the minds of many of you and the minds of many in the public. This is a very good example where these fears have taken on a life of their own. They're disconnected now with the science and what we know, the facts about risk. The fact is that the only vaccine that's routinely administered to children that still contains preservative concentrations of thimerosal is influenza vaccine, and we even have thimerosal-free preparations for young children and for adults. And even with these changes, total exposure, even with this, total exposure is still dramatically lower than it was during the 1970s and the 1980s. In fact, the exposure level is now reduced by more than 99% compared with where the exposures were in the late 1990s. The United States Public Health Service and the American Academy of Pediatrics, as many of you know, issued a joint statement in July of 1999 calling for removal of thimerosal from vaccines administered to young infants as soon as possible. And this was not because the scientific data demonstrated an association with risk for autism spectrum disorders or developmental disabilities, but because there was uncertainty about risk, and this was done as a precautionary measure. Now, all of the analytic studies that have looked at this issue in a scientifically valid way have subsequently not shown any causal association between the use of thimerosal-containing vaccines and risk for autism spectrum disorder. I'm showing you here some ecological data from the California Department of Developmental Services, which is the number of children, number of persons, and these are almost all children, receiving autism services by quarter in California during the period 1994 to 2005, showing the dramatic increase in the numbers that are being served, and raising the issue there was a temporal association of this increase with the increasing dosage of thimerosal in childhood vaccines. Now, if you look at these data from in the more recent period of time from 2002 to 2005, as shown in this bar graph, you see that the increases are reflected not only in 6 to 9-year-old children, which are the yellow bars, but there continues to be a sustained increase all the way through the fourth quarter of 2005, which are the most recently available data, in the 3 to 5-year-old children. That's the blue bars. So the joint statement came out in 1999. By 2001, almost all of the vaccines that were being used in the routine childhood immunization schedule, except for influenza, had thimerosal preservative eliminated from them and gone to single-dose preparations. And in effect, and by the end of 2002, this whole process had been pretty much completed. So in spite of that, even among 3 to 5-year-old children, the increase continued in the number of children receiving autism services. So these ecological data seem to be totally incompatible with the hypothesis that thimerosal is the cause of autism spectrum disorder. If thimerosal was responsible for the dramatic increase in recognized cases of autism seen in the 1990s, it should already be dramatically decreasing in the California data. The California DDS data show no evidence of a decrease, although the rate of increase has slowed during the period 2002 to 2005. The number of children 3 to 5 years old receiving services continued to increase each quarter. So I think these are additional ecological data that support what we know from a scientific standpoint, that there is not a causal association. So bottom line is that there's a good deal of good science now. It does not support a relationship between thimerosal and autism. Thimerosal exposure from vaccines is now lower than it has been for decades. And if the autism rate was going to decrease, it should already be going down, and dramatically so, because of what's happened with the composition of the vaccines. But there's no evidence that this is the case. The bottom line message is that we need to use the vaccines we have to protect children from vaccine-preventable diseases. However, this is a complex issue, as you know, and we continue to have difficult times with this. Some have charged that the ACIP statement of no preference for thimerosal-free vaccines, which is based on the fact that there's no scientific evidence that this represents a risk, that this is seen as inconsistent by some advocates with the joint statement issued in 1995. We still have complex issues to face with the influenza vaccine supply and legislation in a variety of states that has complicated those issues even further. Not all studies are good studies, but it's hard for non-experts. It's hard for the public to sort out the difference. And when we have people like the Geyers who are taking the California DDS data and declaring that they demonstrate that the number of children receiving autism services is decreasing. They turn an increase into a decrease and have actually published at least one paper in an alternative journal that promotes that hypothesis. We have well-organized advocacy groups and ongoing litigation, and the unanswered questions about autism, and a lot of misinformation on the internet that can really confuse parents and the public at large. So to conclude, I hope I've given you a broad view of both of the many successes of the childhood immunization program, as well as the challenges and some of the ethical dilemmas that we're facing as we move forward. But we can stand on the fact that we've achieved record high coverage rates, which has resulted in record low vaccine preventable disease incidence and enormous benefits for our children. And there are more opportunities to prevent disease with vaccines than ever before and help even more children survive and live very healthy, productive lives. But more needs to be done to sustain the immunization system and to address unfounded fears about vaccine safety. So with that, I thank you very much for your attention.